Without further ado, I'd like to introduce Professor Sally Green. Sally is co-director of Cochrane Australia and Deputy Head Research of the School of Public Health and Preventive Medicine at Monash University. She holds a PhD in epidemiology and preventive medicine and has several competitively funded research projects which aim to improve health outcomes by investigating the most effective and efficient pathway of knowledge from research result to sustained change in clinical practice and policy. So of interest to us all, Professor Green is also a member of the NHMRC's Synthesis and Translation of Research Evidence, or STOR advisory group, and is a member of Cochrane's International Governing Board. And today she's going to be speaking to us about implementation science in health services research. Thanks very much, Sally.
Thanks, Rachel, and hi, everyone. Of course, we're in webinar mode, so I can't see you all, but I trust that you're there and you're comfortable, and that if for some reason you can't hear me or my slides fail to go, that you'll let me know by some means or other. Before I start, I'd also like to pay my respects to the traditional owners of the many lands that we're coming from virtually today. For me, down here in Bayside, Melbourne, that's the Boonwurrung people of the Kulin Nations, and I pay my respects to their elders past, present and emerging. There we go. In the interests of full transparency, this is my disclosure of interests listed here. Rachel's covered many of them in the introduction, but importantly to add in the context of this talk is that Cochrane Australia is a partner organisation in the Australian Living Evidence Consortium, and this presentation is drawn from my own research and that of others, and as a Cochrane Governing Board member, I do need to say that it does not necessarily reflect Cochrane organisational policy. I'm well aware that today I'm in the company of many folk with broad and deep experience in implementation, in health service improvement and in research, and I'm very much looking forward to our later discussion. In my presentation today, I'm not going to talk much about complex theory or academic debate in implementation. Instead, I'm going to focus on the reasons why implementation science matters, what it is and the context in which I view it, when best to invest in implementation efforts, and the practical approaches we've tried and evaluated, some successfully, some not so much. So why? Why does implementation science matter? Why does it matter to me? And why does it matter in general? Good research aims to address an important problem, to help us understand a complex issue, or to generate and test potential solutions to move us forward towards impact. The aim of implementation science is to address the complex and recalcitrant problem of just how hard it is to get our good research into practice and policy. Because rigorous research needs to be accompanied by equally rigorous and effective ways of facilitating its use, we need implementation science. We've known this for quite some time. As early as 1936, our Minister for Health recognised the need for both research and also for its timely use. In more recent history, in 2009, the Productivity Commission hosted a roundtable aiming to strengthen the use of evidence in policy in Australia, in which they noted many lost opportunities for the use of research to inform policy in health and more broadly. And globally, over time, the importance of research to health policy has also been well documented. When the WHO convened this knowledge translation workshop in 2005 and labelled bridging the no-do gap as one of the most important challenges for public health in this century, they could not have been aware of that other big public health challenge we're currently living through. But their call for action to bridge the no-do gap holds, and never more so than in response to the pandemic, where we've seen great examples of research informing critical policy and practice decisions, alongside, at times, shocking examples of misinformation, spreading through social media and more broadly. However, the pandemic has provided a catalyst for refocusing on the importance of using research evidence to inform policy development and implementation towards strengthened health systems and equity in global health. The need for best available research evidence has long been recognised by the WHO, most recently in this 2021 guidance to support evidence-informed decision-making, to which I was honoured to contribute as a member of its editorial board. And yet, despite decades of global effort, this gap between research, policy, health system performance and practice persists. One way in which it manifests is in variation in care, examples of which are so well documented in the Commission's Atlas of Variation, now in its 4th iteration. While not all this documented variation is attributable to evidence practice gaps, and may be in part explained by setting, populations, patient preference and the like, successful implementation of research-based clinical guidance is, in my view, likely to result in far less variation. And finally, in my section on why, a key argument for why we need effective and efficient implementation methods in healthcare and healthcare systems is to address the contemporary and increasing problem of too much information. Demonstrated wonderfully in this illustration from the work of my colleague Julian Elliott, the modern healthcare decision maker, be they clinician, policymaker, consumer or carer, is inundated with information, of which research is but one component. We need better mechanisms to support their decisions through curated, up-to-date, reliable, synthesised research and practice data, well delivered, in context, through engaging and effective implementation strategies. So that's the argument for why. What do I mean when I say implementation science, and in what context do I view it? Implementation science is the scientific study of methods to promote the uptake of research findings into routine healthcare in clinical, organisational or policy contexts. Importantly, it is two-way. It is an exchange between research and research use, ensuring both that research is used to inform health decisions and that research is informed by and responds to the decisions that need to be made. And so, following this line of thought, successful implementation requires action both from researchers and from healthcare decision makers. This schema helps in my conceptualisation of implementation science. In it, I've tried to capture the way in which I try to think about it. I want to make the point with this schema that implementation science belongs in all quadrants, in all parts of the evidence ecosystem. Starting up at the top left quadrant in green, it's critical to research being used that it's relevant, that it addresses unanswered questions and is aligned to user needs. This can be achieved through formal collaborative priority setting processes where groups of clinicians, policymakers, consumers and researchers come together to set research agendas and scope important questions. Then, evidence addressing these questions needs to be co-produced in the form of primary studies and systematic reviews, collated into clinical guidelines or other forms of guidance suitable for informed decisions. We know that co-production facilitates later implementation, and also that researchers have an important role in ensuring their research is implementable, and I'll talk a bit more about that later. While all quadrants need an eye to and great methods for implementation, the next quadrant in purple is all about implementation science. An important component in this is that our implementation approaches need to be tailored to the context in which we are implementing our research and our recommendations. Understanding the setting, the local and contextual factors that will impact on the uptake of research is key to what we are trying to achieve. And just as we advocate for evidence-based practice and policy, so too must implementation methods and approaches be rigorously evaluated with impact on practice, policy, and outcomes measured and reported. And in order to enable all of this, we need a catalyst, usually in the form of a pressing user need or an important research finding, the push and pull of implementation. We also need a culture of research use, and we need capacity, a workforce of researchers who know how to conduct implementable research, and a research literate population of healthcare decision makers. One of the questions I'm most frequently asked about is, when should we implement? For me, this is usually in the context of guideline recommendations, but it applies equally to other forms of research findings and research-based evidence. This question is not surprising, given it is widely acknowledged that translation of research into improved clinical practice is challenging, with complex barriers at multiple levels, and it takes considerable effort and resource. In a healthcare environment where there are multiple competing demands for finite resources, implementation efforts need to be prioritised. Trying to address just this question as it relates to guideline recommendations led us to develop these when to implement criteria. Working with our colleagues at the Stroke Foundation and in the context of the over 400 recommendations in their living clinical practice guidelines for the care of people with stroke, we designed and subsequently used these criteria to prioritise their implementation efforts. First, we want to be pretty certain that the research and/or recommendation we are implementing is reliable. And we need to know that we can measure current practice or policy and that it is non-concordant with research or variable. The efforts should, of course, be directed at areas of clinical importance as judged by consumers and clinicians and health services and policymakers in context. Finally, priorities should be feasible and cognizant of the broader impacts and opportunity costs. For the remainder of our time together this afternoon, though, I want to focus on how. I started down this implementation and knowledge translation journey many years ago when I was a physiotherapist dabbling in Cochrane reviews and asking myself how to take the results of my reviews into change in practice and policy and ultimately benefit the health of my patients. The following is a bit of a whistle-stop tour of where my travelling companions and I have landed. And while I will try to present it in a clear roadmap for the purposes of clarity and structure, I should declare that we've taken many a detour and got a little lost many times along the way. Let's start with the research itself. Are there things that we as researchers can do to make our work easier to implement? This concept led us to undertake a review of characteristics that had been shown to influence what we termed implementability in the context of randomised controlled trials and resulted in the development of guidance for the Australian Clinical Trials Alliance, or ACTA. While specific to trials, many of these criteria hold true for research in general. Characteristics such as consultation and co-design with end users, understanding the context in which your research will be used, following rigorous research design appropriate to your question and hypothesis, ensuring representative populations, selecting relevant outcomes, managing conflicts of interest, and reporting that is complete, transparent, and timely. This flowchart comes from a practical approach we developed to help operationalise theory to guide choice of potential strategies that could be used to implement a research finding or recommendation into clinical practice once it was published or completed. Use of theory provides a structured approach to thinking in detail about the change needed to implement a research finding, who needs to do what differently, then working through the potential barriers and enablers to that change in a particular setting or context. Step 3 involves drawing on theory and evidence to match or tailor a particular intervention to that specific context, while step 4 again reflects the importance of being able to measure any change. Our early work harnessed the theoretical domains framework, a validated approach to understanding clinical practice and behaviour. We later adapted the same approach using organisational theory, such as the diffusion of innovation, and multifaceted theoretical frameworks, such as the consolidated framework for implementation research, to apply the same practical stepwise approach to understanding barriers and enablers and selecting tailored interventions in health services and organisations where who needed to do what differently required approaches beyond change in individual clinical practice. By way of example, we have used this approach to understand practice and inform the potential for change in many settings and for differing clinical and organisational practices. All of these examples are published and we can discuss them later if of interest, but some listed here include imaging for low back pain, both in primary care general practice and in physiotherapy and chiropractic clinics, management of post-traumatic amnesia in emergency departments, looking in the context both of individual clinical behaviour and organisational change, dementia diagnosis in primary care, imaging for pancreatic cancer, screening for sleep apnea in people living with tetraplegia, multidisciplinary team meetings for cancer management in acute settings, and diabetes care across a range of acute, primary, tertiary and secondary settings. There are many potential interventions to support implementation, and we don't have time to discuss them all today. Examples include education and professional development, reminders, opinion leaders and change champions, financial incentives, as well as more complex organisational and system redesign. What we do know from evaluative studies that it is likely that we need a system approach with more than one strategy employed, and that we are more likely to be effective if we tailor our approach to the local context and an understanding of the barriers and enablers for change. For example, drawn from approaches such as the one we've just discussed on the last slide. Audit and feedback of performance is incredibly important and underpins much of our current approach. Reflecting this, more than 140 evaluative studies have evaluated the effects of audit and feedback. And we know it is most effective in settings where concordance with evidence is low at baseline, if the person giving the feedback is a supervisor or a colleague, if it is provided more than one time and in more than one format, and if it contains specific targets or benchmarking. So drawing some of this together, you will no doubt have heard of a learning health system. While there are several models, the principles are similar and pull together many of the concepts we've talked about today. A great example in Australia is in stroke. The input of external evidence in the form of living clinical practice guidelines, feeding in to the knowledge to performance loop, informed by data collected in the registry, and then measured through national audit to again generate more knowledge and feed back into the ever-improving system. All this resulting in a learning health system cycle, implementation science in action. For the last few minutes, I thought I would talk a little bit about increasing capacity for research use in policy and discuss our Spirit Action framework, which was developed in partnership with colleagues from Sachs Institute in Sydney. If we're thinking about implementation science as a collaborative partnership, cyclical push from researchers, pull from policy endeavour, then we need to understand ways in which we can increase the capacity within policy agencies to use research, combined with increasing the capacity for researchers to partner and disseminate and translate their research. This led to us developing what we call the Spirit Action framework, which underpinned a later step-wedge study of an intervention aiming to increase capacity within policy agencies for the use of research. While this model looks a bit messy on the screen, I wanted to show it for a couple of reasons. First of all, I wanted to highlight that in the big cloud up the top, the semicircle above the linear model, is all of the other things that can feed into policy, and the important point that research is but one of those. So this framework is about improving our capacity to use research while cognizant of the many other drivers of policy. Across the bottom is a series of actions that we used, or a series of concepts that we use to understand the way in which policy may be used in research, and the kinds of capacity and capabilities that we wanted to improve. We recognise that policy, evidence-informed policy, is often commenced with a catalyst, that it took capacity in agency staff, that it resulted in a number of research engagement actions, and that the outcome was research use in policy making in a number of different ways. Important to this model, however, is that there is a reservoir of relevant and reliable research addressing policy questions on which policymakers could draw. We tested this model in a step wedge trial, an intervention of audit, feedback, and deliberative goal setting, combined with values, tools and systems, and knowledges and skills, delivered in 6 health policy agencies in a step wedge trial over 18 months. In this, we found that participation in spirit was associated with significant increases in research use capacity at staff and agency levels. So in closing, I wanted to really loop back and reflect where I started, which is the concept that implementation science, being the study of the methods, of the ways to implement our research into practice and policy, must take rigorous evaluation of our methods in the same way that we would of the knowledge that we are implementing. It must involve partnership and collaborative working between the producers of research, researchers such as me, and the people who we serve in the decisions that they're trying to make, be they patients, consumers, carers, policymakers, or clinicians. Thank you.
That's terrific. Thank you very much, Sally. That's been an excellent both overview and also in-depth, touching on some of those really important examples. We do have a few questions and answers that have come up now, but I'll give people a couple of minutes to formulate their questions and type them into the Q&A. I'll just ask you a practical question, Sally, perhaps drawing on your experience from stroke implementation, science research, or others. What did you find were the main barriers or categories of barriers for medical clinicians and other health clinicians in terms of implementing guidelines? What from the stroke examples, what were the main things that you found were really the objections or the barriers? Yeah, just interested to start off with an applied example.
Yeah, it's a really good question, Rachel. And with your permission, I'm not going to focus solely on stroke, not for any reason of not wanting to disclose that, but simply because I might not get, my memory may not get them right, but just to talk in general terms around barriers to implementation of guidelines by clinicians. This is where, in our experience, the approach that we've taken is to use the theoretical domains framework. And the theoretical domains framework is a really important theoretical tool that combines many behavioural theories and importantly has been validated in clinicians. It's been validated to accurately describe and predict what I'm going to call clinical behaviours, the things that we as clinicians do that drive our decisions and drive the way that we practice. And led by Susan Mickey and others from University College London, they've come, and Jill Francis here in Melbourne, they've come up, Melbourne in Australia, they've come up with a set of constructs that broadly map to things like knowledge, skills, social influences, belief about your capabilities, organisational issues, emotion, and different constructs when you use this framework to really explore barriers with qualitative work with clinicians. When you can underpin and map them to these frameworks, you can really start to see the similarities and differences in the way that different types of recommendations play out in different kinds of settings. So for example, in our work in primary care driving X-ray use, we thought, well, actually, we got it completely wrong. We thought there might be a number of things driving that, but in fact, we found that it wasn't so much the knowledge domain, but it was more the patient expectation and belief about consequences and social influences domain, where X-rays were perceived to be needed to provide reassurance to people who perhaps thought they were more injured than what they eventually turned out to be. So that's just one example. And all of those studies that I listed have used the theoretical domains framework to map to various concepts within that framework and help us understand. And then, of course, once we understand that, we can make better, more tailored decisions about the kinds of interventions to use. So if people are forgetting, if memory is the construct, then maybe reminders is a good idea. If people actually think that they're doing something that they're not, then audit and feedback might work. If it's an environmental issue, then providing additional resources might work to simplify it a little.
So just picking up on that notion of the intervention being something you wanted to de-prescribe or de-implement, I guess the X-rays, and I think that's a really interesting and challenging area. I know there's people on the call who are doing that sort of work now. The reassurance gained by a test or a diagnostic test or a procedure, were there particular other strategies or interventions that could take the place and provide that reassurance? Because we do hear that is a common reason for, even doing surgeries.
Yeah, well, we actually went on to test a number of strategies in a cluster randomised control trial in that setting. And the strategies that we used were, we did play into the knowledge, but we did more knowledge around alternative ways of reassuring patients. We used opinion leaders. We had some very senior GPs deliver workshops around ways in which you might interact with the patient in that kind of circumstance. And we did do some kind of feedback looping around, there's a number of X-rays that you're ordering, here's the evidence around why that may not be necessary, and try to sort of a number of different strategies that tailor those barriers that we came up with. But your point around de-implementing is interesting. We know, and you will have seen on the audit and feedback slide, that different strategies work for different kinds of behaviours. So some things that might work when we're trying to get people to start doing something may not work in the same setting with the same people when we're trying to get them to stop doing something. And that's why that nuanced understanding of the context is really important to help plan strategies.
Terrific. I think that's really helpful. I'm now going to go to the Q&A. So the first question is from Mark Owusu, and I'm just going to read it out as it's written. When talking about the conceptual framework, Sally, you talked about tailoring implementation to the context. Usually we read about type 3 error, where policies may not be implemented in accordance with the original evidence base used to design a program which may affect the desired outcomes. In your view, how could this problem be avoided or reduced? Do you want me to read any of that out again?
Just let me check that I've got the understanding right. So this is around error about really the sort of, it's almost like fidelity, like the implementation error, that it's not rolled out in the same way that it was planned. We've thought about this quite a lot in the context of some of our evaluative studies where the intervention that you're implementing may not be exactly the same as the implementation as designed. And that's why it's really important that there's always a process evaluation conducted alongside these kinds of implementation evaluations and trials so that you can measure not only was the intervention delivered as designed, but was it received by recipients how it was intended to be received. And here theory can help us quite a lot as well. We can think about whether or not the main sort of theoretical components of what we were trying to deliver, the main behavioural constructs were met in the delivery of that intervention. I think in terms of the question around ways that the policy can be rolled out sort of true to its plan is, you know, in my view, really, again, all about the planning. I'm very mindful that policy making is complex and I'm not a policy maker, but I think, again, this kind of detailed implementation planning where the implementation strategies are based on a really thorough understanding of the context in which it's going to be delivered, and then process evaluation and policy evaluation along the way so that we can understand if the effects are due to the intervention itself or issues in the way in which it was delivered is really important to grow our understanding. Recognising, of course, that's resource intensive, we can't do it every time, but again, thinking about the sort of criteria for prioritisation where we might want to put those really rigorous evaluation frameworks around that.
Okay, great, thank you. The next question is from Monica Janda. Can I ask what role direct observation plays in data collection? At what time point you might apply this, as we know that self-reported data can be biased, especially when asking about difficult to change behaviours. So the role that direct observation plays in data collection.
Yeah, we haven't done any direct observation in our evaluative studies. We've done, I tend to think about this as sort of along a bit of a pathway, recognising, of course, that it's not linear, but just to help me in explaining this. So the first thing that we might want to look at is the clinician, let's take clinicians by way of example, the clinician's knowledge. So if we're wanting to implement a guideline, for example, or a guideline recommendation, say it's around screening for sleep apnea, the recommendation may be that people with tetraplegia need to be screened for sleep apnea. The first thing to then measure will be, do the clinicians know that? You know, have they ticked the sort of the knowledge box on the way through? The next step along the chain is intention. You know, if they know it, do they intend to do it? So again, you're measuring their intention, and there are validated ways to do that. And then the next step is around their self-reported practice. Did they say they do it? And then the final step could be direct observation, or it could be another measure of actual practice. So was there a referral slip? Is it recorded in the notes? We've done some work around extracting recorded practices from the notes. Do we have another sort of concrete or objective measure of whether or not they actually implemented the practice? The next, somewhat more challenging and certainly more resource-intensive step is to measure, and did that make a difference to the health outcome of the patient at the end? Now, if you're able to nest something within, for example, a registry, then you may be able to get some indication of that. If you are there's a really interesting discussion to be had around if you are implementing a practice that is, you know, well demonstrated to be effective. There's multiple studies, there's a body of evidence to show that if you do X, it will result in Y. Do you then need to measure at the level of the patient, or are you okay to stop at measuring whether or not the practice happened? If you're less certain, you might want to measure, and then did that result in patient uptake. So cluster randomised controlled trials and step wedge studies of other designs that are looking at really rigorous evaluation of implementation strategies will do both. I don't have current data on this. It's a very old study, but very early in my career, we did a bit of analysis of various implementation studies looking at the numbers that measured, you know, only up into the level of did the practice happen, and the numbers that then measured at the level of the patient. It was about 80-20, I think.
Okay, that's very interesting, very useful. Thank you. The next one's about the theoretical domains framework. It's a question from Anonymous. Can a theoretical domains framework be applied to analyse data from a qualitative study to determine strategies to resolve raised barriers?
Yes, it can. In fact, we've done a number of those, and we have looked. The way in which we've used it is to use the theoretical domains framework to guide the interview schedule. So to ensure that we were asking, open-ended, of course, but asking questions that touched points on all of those constructs. So are we asking questions about their belief, about consequences, about their knowledge, about their skills, about their social influences, about their role definition, and a number of the other constructs that happen in the theoretical domains framework, so that we make sure that we're exploring, all of those areas. And then, of course, it can, like most theories, be used as a analysis framework for thinking about how to interpret and make sense of those results. So yes, it can. There's quite a body of work about that, and it's certainly been an approach that we've enjoyed, and that I think's led to some better and more structured understandings about why things play out in the way that they do.
Okay. Terrific. Still on the topic of the theoretical domains framework, this question's from Kathy Dempsey. Sally, do you always use the theoretical domains framework, or do you find other frameworks maybe more useful for different problems?
Yeah, it's a good question. We've done the most recent one that we've done in diabetes. We use the Consolidated Framework for Implementation Research. As I think, or I hope I said, in areas where we might be looking at sort of organisation and systems level things, we've used the diffusion of innovation theory to sort of loosely, in a similar way, to help us come up with interview schedules and to help us with the analysis and understand the work. And in fact, one of the projects that we did, which was called the NET trial, which was looking at the assessment of and management of post-traumatic amnesia in emergency departments for people who'd had mild brain injury. We did both. We did a series of interviews with clinicians, with nurses and doctors, people working in emergency departments, that was underpinned by the theoretical domains framework. And we did a series of interviews with managers and directors of emergency departments, which we used the diffusion of innovation, where we asked questions more related to the way in which their information systems were set up and the way in which they manage things at systems level, brought those two things together to design the intervention that we subsequently tested in the cluster trial. So short answer is yes. I'm sure that I still have lots to learn in this, and that there are many other theories and approaches and ways that we can do this. But to date, it's the theoretical domains framework that we have used the most.
Okay. Terrific, thank you. The next question is from Jeffrey Bryant. Sally, how can implementation science help where barriers are couched in ethical rather than clinical or outcome terms? And the example here is a distaste for performing living donor kidney transplantation due to unintended consequences for the donor. So how can implementation science help where barriers are couched in ethical rather than clinical outcome terms?
Interesting question. This is where I wish I could see faces, Rachel. I'm very much enjoying talking with you, but I'd like to be able to go backwards and forwards on this question. I think if we think that through, if we go back to sort of that first principles definition of what implementation science is, which is a study of the methods to implement, that's a fairly broad grouping. So one, I'm not an ethicist, but I would think that there would be a range of approaches that you could use around eliciting patient preferences, understanding the context, sort of, I don't want to say barriers and enablers, it doesn't feel like quite the right word, but sort of understanding the nuances about why things are unfolding in the way they do from the clinician perspective, from the organisational perspective, and from the recipient and family's perspective. If you're doing that in a structured way and evaluating it, then that is implementation science. because by definition, it's a study of the methods around implementation. So I think the approach, that sort of approach of evaluating, thinking through structured approaches, documenting, and trying to sort of evolve the science over time is going to be helpful. However it pans out. I know that's sort of only half an answer, but interesting debate, something that would be really interesting to think through.
Well, it sounds like there are similarities there. It's sort of ignoring that, that there might be clinical benefit, and we know that, that happens a lot. The evidence says there's clinical benefit, but there are other objections. And in this case, I guess it was, ethical concerns.
That's right. And that's sort of the overlap with the shared decision-making research as well, isn't it? That bringing the evidence to the table, but also putting equal weight on the patient's values and preferences, and putting structured approaches and ways of working around that, and then evaluating the model.
Now we've got quite a few questions that are all about resources, where to go for other resources. So I'm just going to touch on the types of areas in which people would like resources. The first one is from Arleta Willman, who works in a local health district in New South Wales, who asks, what resources would you suggest to increase the implementation science capacity for our health promotion staff? So that's for health promotion. And then there's a general question about resources for emerging researchers with interest in implementation science. And then a third question about resources for GPs specifically. And that is, GPs manage, multiple conditions. Being up to date with current treatments and strategies for all of those is very difficult. What resources can GPs pull on, particularly when they're dealing with a condition that they only see infrequently?
Good questions, sort of different answers. So a sort of easy response is to say I can certainly make the reference list from this presentation available, Rachel, for
yes, we can distribute that to all the participants.
That's fine. I can do that. For emerging researchers, there's a number of in that reference list. There's a number of sort of theoretical papers that I can add to the list. I haven't referenced them directly in my slides, but I can certainly add some of the work around the theoretical domains framework, for example, to that reference list, and also a couple of websites which might help. So I can send those out. On the question of GPs and health services, what I didn't talk about today, my current co-passion with implementation science is, of course, living guidelines, living clinical practice guidelines, and living guidelines for policy. And this comes from the work of the Australian Living Evidence Consortium and its innovative new methods for guideline development, which I would actually put into implementation science as a mechanism of improving implementation, is, of course, having well presented, curated, and collated, synthesised bodies of evidence around important clinical questions. So I talked about stroke living guidelines a little bit. There are living guidelines also in diabetes, importantly in COVID-19, led by the National COVID-19 Task Force, and a number of other areas, musculoskeletal included. So on the issue of GPs, one of my hopes is, I certainly empathise and well understand the challenges of treating multiple conditions and needing to be up to date with evidence across a really huge portfolio of clinical practice. And one of my hopes is that a living guideline model where guidelines are updated as new research emerges lends itself to different technologies and ways of presenting evidence. So instead of having the big tome of, the clinical practice guideline that gets updated every 4 years, it sits on the shelf, holds the door open, whatever else it's used for. We have sort of digital versions of guidelines that are updated in real time as new evidence becomes available. And as clinicians, we we get sort of used to that evidence is dynamic, that research is dynamic, and what was the recommendation, particularly in areas of uncertainty where things are changing quickly, that we need to be checking those, and that there are good sort of push-pull strategies around that with notifications, and that the evidence will be there, at the point of care when you need it, not when it happens to come out from the guideline developers. So I know that doesn't solve all of the problems of needing to be across such a big portfolio, but I am optimistic that living guidelines and that change in culture around being a bit more uncomfortable with uncertainty, that we do need to keep an eye on this because it's moving over time, as opposed to being the holder of all knowledge, will lead to a more efficient and hopefully more engaging way of working with evidence.
Okay, no, that's great. And let's hope we can find the funding to continue the work to continue updating the guidelines as well. So just on resources, was there anything specific for health promotion, or would health promotion, implementation science in health promotion, would that be covered by the other resources that you might send to us?
It may be. You may need to leave that with me for a bit. Let me have a think about that and a look. I'll certainly label anything I send in that. I don't have anything off the top of my head, but let me have a look. Certainly the more general methods papers will be helpful, but let me have a look if I can.
Okay, lovely.
Health promotion.
Thank you. We've got a couple more questions, and we'll go until 2:55 Sydney time. The next question is from Ranjit Najara. In a knowledge creation process that is collaborative, and in brackets Gibbons, implementation may concurrently happen in very diverse contexts and settings. Is there an implementation readiness to be developed and considered within implementation science, somewhat similar to diffusion of innovation for health services knowledge translation in particular?
Yeah, it's a good question. I think so is the answer. I think this is the point that I was trying to make, which I actually find quite hard to explain. It's not because it's complicated, but because I haven't quite got my articulation right around it. But there's something about the implementation way of thinking, an implementability lens right from the beginning of doing your research. That when you and that's why collaborative multidisciplinary processes to set research priorities, to design the studies, to produce the studies are much more likely to lead to successful implementation, because if you've got collaborative structures up front with people from diverse settings, places where this is going to be rolled out, inputting right from the beginning, then not only is your research likely to be more implementable because it will be done in consideration of all of those contexts and barriers and complexities, but also the people who are going to be using and benefiting from your research are involved right from the beginning, so they know about it. There's that sort of sense of involvement, and that thereby leading to better uptake and implementation, because the research is more relevant and arguably more trusted because they've been involved in the process. Now my thinking and experience about that is more in the area of guideline development and research synthesis rather than primary research, but I think the principles probably apply. I think we're beginning to understand a little bit more about this, and with co-production and co-creation of research becoming much more frequent. Yeah, we'll be able to see how this plays out over time.
Okay. The next question is about low and middle income countries. It's from Marcus Uwu. Regarding information overload, I believe it depends on the context. In low income countries where data or evidence is a major issue, what prospects are there for implementation science approaches?
Yeah, good question. I have been really fortunate in my career, and particularly through my leadership of Cochrane, to work a lot in Southeast Asia, and particularly in the context of maternity care and neonatal infection. And we've worked with colleagues across Southeast Asia on some of these approaches around implementing and making available evidence in sort of key areas of pregnancy care and delivery and neonatal, particularly in NICUs. And in fact, that whole sort of work around applicability of evidence, you know, the person asked the question is quite right. We don't have anywhere near enough directly applicable evidence in diverse settings, low middle income country and otherwise. You know, we could talk for ages, Rachel. I know about, you know, populations that are excluded from research studies, for example, and the way that we need to work collectively to try and do a better job of that. But I think, you know, I think there's more capacity than one might imagine, and more ability to use strategies around education and audit and feedback, and some of the other strategies that have been tested in our settings, in low middle income countries as well. I don't see quite as many barriers as what one might think.
Okay. And finally, what do you think are the priority areas for implementation science in healthcare?
Well, that would depend on your bias. I would say a focus on implementing bodies of evidence. So systematic reviews, clinical practice guidelines, looking at setting priorities around areas where we have bodies of evidence, a reasonable certainty, and being able to think about, you know, where there are gaps in practice and focusing our attention there. I think that in all of the areas where we have great policy and practice need, you know, areas of equity, areas of climate health, areas of, you know, chronic disease, areas, you know, emerging epidemics, in all of those high priority areas, whatever they might be, and that they're just some examples where implementation science should play a part. So in my way of thinking, when we're thinking about using research to inform and move us forward in big global challenges, we need to be thinking about methods of the way in which we conduct the research and methods in the way in which we implement the research at the same time and together, rather than thinking about the researchers do the research and then someone else does the implementation. It's around setting up these collaborative structures so that we can think about bringing together big multidisciplinary collective teams to tackle problems rather than working in silos. So I think that's the next frontier, really, is being able to build those collaborative spaces to be working together, so right the way around the ecosystem.
Terrific. Well, I think that's a really nice note to end on, actually. It really does, you know, summarise some of the future directions. Sally, it's been an absolute pleasure to listen to you today, and thank you very much for your really thoughtful responses to the questions as well. Thanks to the participants for your engagement and for your questions. And as we had said, Sally has given permission for the recording of this to be sent out to all of those who've registered, and it will also be on the HSRAANZ website under the webinar section. So on behalf of the association, thank you very much, Sally. Wish you a really nice rest of your afternoon, and happy Easter to everybody. And do look out for the Health Services Research Conference at the end of the year.
Thanks so much, Rachel. Thanks, everyone. Bye.
Bye-bye.